to everyone. So I am Dr. Manoj Pahukar. So on behalf of Young Surgeons Forum, I welcome you for this 23rd episode of this YSF series. As you all know now, this is with MOA Maharashtra Orthopedic Association, and this being a brainchild by Dr. Wasudeo Gadegone to give the platform for young orthopedic surgeons to showcase their work on this global platform. We are very fortunate for this 23rd episode to have pediatric orthopedics as a theme for this today's session. And the theme for the today is of the complex elbow trauma, not just supracondylar fractures. Dr. Mandar Agashe is the convener for this today's YSF series. He has already made my job very easy. He has designed wonderfully. The first will be having 5 talks in the initial first session, and it will be followed by a few case discussions. Dr. Avi Shah will be the moderator for this today's session along with Dr. Mandar Agashe. And we are very fortunate to have 2 eminent panelists, Dr. Sandeep Patwardhan and Dr. Viraj Shingade. The famous pediatric orthopedic surgeons will be guiding us and giving their important discussion tips during this interactive session. So without much further ado, may I ask now Dr. Gadegone sir to give a brief introductory welcome for this today's episode.
Good evening, sir. On behalf of Maharashtra Orthopedic Association, I welcome you all dignitaries, those who are going to give their talk on this Young Surgeons Forum webinar. And I also must thank Mandar Agashe, Manoj Pahukar, and Sandeep, senior this pediatric surgeon Sandeep Patwardhan, and Viraj Shingade for their kind consent to be here as a panelist. And I hope this webinar will be very interesting as well as it will be educative to the young orthopedic surgeons all over Maharashtra and as well the viewers of Ortho TV. So I welcome you to this episode of Young Surgeon Forum, and it is your endeavor to give a platform to the all young orthopedic surgeons all over the Maharashtra so that they can show their work. So over to Mandar Agashe.
Thank you very much, Dr. Gadegone sir. I would like to thank Dr. Manoj Pahukar also for guiding me for this session. And I would like to thank MOA for allowing me to present in this YSF series. So today what we are going to do is we are going to discuss a few different fractures around the pediatric elbow, not just supracondylars and not just routine supracondylars also. We are going to have the lesser known fractures, which always stump us when we see them in clinical practice. So we have 4 of my friends who are going to talk to us about these fractures, and then we are going to discuss a few cases which had in fact stumped all of us when they presented to us. So firstly, I would like to welcome Dr. Sameer Desai, who is an eminent pediatric orthopedic surgeon at practicing in Pune. He has been trained extensively, not just in India at the Viranchi Vaidya hospital, but also abroad with his international fellowships. And he practices at various hospitals in Pune. Dr. Sameer Desai will be discussing about a very unique injury, which is the medial epicondyle and medial condylar fractures in the pediatric elbow. Over to you, Dr. Sameer.
Yes, thank you, Mandar, for your kind information. And I'll be sharing my screen. So medial epicondyle and condyle fractures, decoding the enigma. So today we'll be discussing pediatric elbow fractures and importance of knowing how to read an elbow X-ray. So let us go through this case first. So this was a 12-year-old male child who came with history of fall. And if you look closely, you can see something over there in the lateral view. This elbow was reduced. And again, I'm mentioning the age. This is a child who is 12 years old. And you can see that the lateral epicondyle is visible, but the medial epicondyle is not visible. So this should make you suspicious that something is missing. So if you see the lateral X-ray closely, you can see that there is a small fragment over there, which is naturally the medial epicondyle. And in such cases, you must look for ulnar nerve symptoms. So this is the CT scan picture. And what is important to remember that 20% of elbow dislocations have an incarcerated medial epicondyle fragment. So is there any close reduction maneuver that has been described? Yes, there's a maneuver that has been described. It consists of a valgus stress with forearm supination, with finger and wrist extension, and elbow is repeatedly flexed and extended. This method uses muscle forces to extract the fragment. However, in this case, we were not able to achieve a close reduction. So we decided to open, we isolated the ulnar nerve. There was a rent in the capsule, the fragment was removed, and this is just a short video demonstrating removal of the incarcerated fragment. And the fragment was reduced and fixed with a CC screw. So a lot of residents ask me, should we have a bicortical or a unicortical purchase? It is said that a bicortical screw placement has got a risk of injury to radial nerve. And what is important to remember that you should not over tighten this screw because it can communicate the fracture fragment. So what are the expected complications? Stiffness is a very important complication. Hence, you must try to mobilize these fractures early. Ulnar nerve symptoms, screw head prominence, and intra-articular extension. So which is the ideal method of fixation? What does literature say? Biomechanically, screws were stronger. K-wires can be used in younger patients. Early mobilization was possible with screws, and use of suture anchors, where people have started using this quite recently, avoided second surgery for implant removal. Let us look at some facts. Medial epicondyle fractures represents 11.5% of all elbow fractures in children and adolescents. It is the attachment point for the flexor pronator mass of the forearm and the medial collateral ligament of the elbow, and the anterior oblique ligament of the MCL serves as the primary restraint to valgus stress, and hence it is important in sportsmen. Everyone knows the mnemonic Creto C, and let us look at the normal ossification centers of elbow. The capitulum appears at 1 year. The radial head appears at 5 years. The internal epicondyle or the medial epicondyle appears at 7 years. The trochlea appears at 10 years. The olecranon appears at 10 years, and the external epicondyle or the lateral epicondyle appears at 11 years. So it is important to know these centers of ossification when they appear and when they fuse. So what is the ideal location of center of medial epicondyle when you plan to fix it? So you draw a line along the inferior margin of the fossa, and in the AP view, this lies 0.5 mm below this line. And in the lateral view, if you draw the posterior humeral line, the center lies 1.2 mm anterior to it. So you should remember that the medial epicondyle is posterior. Hence, when you are going to pass the screw, you're going to pass it from the posterior part to the anterior part. A lot of times, this sort of X-rays sent to us by our colleagues to know whether this type of fracture should be operated or conserved. So what are the factors that you should consider? Patient age, fracture displacement, whether it is more than 5 mm or not, arm dominance, what is the sports participation? We have already discussed about MCL, and associated elbow dislocation. So what are the radiographs that you will take? AP and lateral view of elbow, internal oblique view to evaluate the displacement. But what has been the recent thing in literature is the distal humeral axial view, which has been shown to have very good inter and intra-observer reliability. I'll show you how to take it. And a CT scan can be done in some cases. So this is how you do a view. It is obtained by angling the beam 25 degrees anterior to long axis of the humerus. So what are the long-term results, whether you should conserve or operate? So this was a paper published in JBJ's 2001. For a displacement of 5 to 15 millimeter, close reduction and open reduction yielded similar long-term results. And the non-union of epicondylar fragment did not adversely affect the functional results. However, there are also points in favor of internal fixation. So let us look at them. Non-union rates are seen in approximately 90% of non-operatively treated patients. And non-union rate is only 7% in operatively treated patients. Non-unions are often asymptomatic, but the deciding factors in patients who become symptomatic are not known, and radiographs cannot measure displacement accurately. So this is very important. So radiographs cannot measure them very accurately. So when you say 5 mm, we don't know whether it is really 5 mm or not. And what are the indications for operation? Traumatic or high energy injury or dislocation mechanism, open fractures, ulnar neuropathy, incarcerated fracture fragment, as we have seen in this case, elbow instability, and of course, significant displacement. Now let us look at medial humeral condyle fracture in childhood. It is often a rare but often overlooked injury. The fragment has a metaphyseal part, which is the medial condyle, and a cartilaginous trochlea. The risk of making a wrong diagnosis is higher in children younger than 6 years. This is important because you may get a child with history of trauma and a fracture and a swelling, but you can't see a fracture. So you must suspect it, especially in a child who is less than 6 years. And the trans epiphyseal fracture type Salter-Harris 4 leads to growth disorders with a high risk of non-unions. So there is a Jacob classification. There are 3 types. In type 1 is an undislocated complete joint fracture in which the joint cartilage is intact. This is an incomplete so-called hanging fracture. The type 2 is an undislocated complete joint fracture which may dislocate. And the type 3 is a complete dislocated fracture with a rotated fracture fragment. So the sign that has been described is a C sign, and the medial condyle fragment looks like a C as it is rotated. So in this case, you can see over here that this is the C sign. In this case, you could fix it with K wires as shown in this photos. So what are the complications? Of course, limitation of movements. AVN, open reduction, carries the risk of avascular necrosis of the trochlea, and non-union if the posterior condyle is stripped off during surgery. Physeal arrest, delayed ulnar nerve palsy, and of course, non-union has been reported in 7.4 to 33% of the patients. Thank you.
Thank you, Sameer, for this excellent and very precise talk about medial condyle and epicondyle fractures. I just have one small query. You mentioned about internal oblique X-rays for medial epicondyle fracture. I think there is an article by Eric Edmonds also regarding it. I'm quite skeptical about this internal oblique X-ray, because usually what we feel that in a medial epicondyle, the external rotation oblique X-ray will be much better. So what do you feel about whether to do an internal rotation oblique X-ray or an external one?
What has been described in literature is mainly internal oblique X-ray. I have not come across external oblique X-ray, but logically what you are saying is correct. Probably we should, in our cases, we should also look at external oblique views.
Because usually for a lateral sided injury, it is the internal oblique X-ray which is used. So, so what is your preferred method of fixation? It's always a screw, or do you use a K-wire for a young child?
In a young child, definitely I would go with a K-wire.
Right.
And the other advantage is naturally there is no second surgery required for implant removal. But in an older kid, especially suppose if he's a sort of a Malcolm or a wrestler kid who is training, nowadays we do get these kids. So we would definitely prefer a screw in those kids.
All right. Yes, Dr. Manoj.
I do just have one query, the same continuation. Like in adults, these are like the avulsion fracture injuries, which nowadays we try to treat with the suture anchors more commonly.
Yes.
They do have got a very good anchorage, don't need to take out. So what is the current role in pediatric practice as to the use of the suture anchors for this kind of injuries? If the fragment is especially smaller one where you cannot get a good bite of the screw many times.
Yeah, yes, sir. I have mentioned in my talk that people have started using suture anchors in pediatric population. I have not used it as yet, but there are some papers which say that yes, but they say that you need to, there is a risk of pull out. That is what they have mentioned. And they also have mentioned that probably a screw is better. But there are some studies that are going on. And now if you go through literature, there are more and more people who are shifting towards using suture anchors. But I have not used it. Probably next time, especially as you mentioned in a comminuted fracture, we should use it.
Okay. Okay.
All right.
Sameer, any comment regarding the use of washers? Amit here.
Yeah, you could use, yeah, so, you could use a washer, but I have never used a washer, but you could use a washer, yes.
Can I just say on the washer? So there are quite a few newer publications which have said that use of washer has caused a lot of irritation, and those patients do poorer as compared to the ones who you do not use a washer and you end up having to remove it early. So most recommendations are not to use a washer wherever possible. I mean, not to use a washer basically.
All right. So we'll go to the next one. Thank you, Sameer, for this excellent talk. The next talk will be by Dr. Viranchi Vaidya. Dr. Viranchi is the leading pediatric orthopedic surgeon practicing at his own hospital at Aurangabad. He has trained extensively in South Korea and does a lot of pediatric trauma in his practice. So he'll be talking on another injury which is quite unusual, which is the radial neck fractures. And there are various means to treat it: wires, plasters, nails. So let's see what Dr. Viranchi says about these fractures. Over to you, Dr. Viranchi.
Thank you, Mandar. Thanks for a kind introduction, and thanks MOA for giving this opportunity. So as Mandar said, we will be discussing about radial neck fractures, whether it is plasters, pin or nails. What is most important is there's this statement by this gentleman, Dr. Roger Cornwell. He is an upper limb surgeon in Cincinnati. In his commentary published in 2013, JBJC said that we are all afraid of radial neck fractures that need surgery. But why and what should we do about them? Now, this is a very open statement and a very, I would say, a kind of reflection from him, somebody who is working in upper limb. This is what we all feel when we are doing radial neck fractures, and we are following up the radial neck fractures treated conservatively as well as operatively. There are many questions about radial neck fractures precisely because the incidence is very low, so we don't have a lot of experience in our practice. The important thing is that if you ask proper questions, then you are probably going to get correct answers. Of course, you need to match these pieces of jigsaw puzzle so that you can come up with the answer. There is no one clear-cut answer. We will see it as we go through the slides. This slide is most, we would say, applicable when it comes to radial neck fracture. When we go to literature, there are a few people who talk about age. There are a few who speak about initial deformity. Few speak about the method of reduction, whether it was done open or closed. But when you go through it, then you don't get one holistic picture. The purpose of the talk and discussion today is going to try and arrive at a consensus so that we can treat the patients accordingly. Let's start with some basic facts and figures. As we said, it's a very rare fracture. 1.3% of all fractures, 5 to 10% of pediatric elbow fractures, commonly between 8 to 12 years of age, said to be more common in girls. The gender bias is because of the excessive valgus that they have anatomically. The mechanism of injury is usually fall on outstretched arm, or it's associated with elbow dislocation. And what's very important is that the frequency of associated lesions is around 15 to 60% in different literature. Now, these things have to be remembered when we think about treating these fractures. As we said, injury is of two types. One is a fall on outstretched hand. Basically, the capitulum presses on the radial head, and because the radial head is covered with cartilage and it is strong, the neck part, which is relatively weak, gives away. And depending on the position of the forearm, whether it is supinated, neutral, or it is pronated, the head is going to get displaced either directly on the lateral side, a bit anterolateral or a bit posterolateral. In contrast, in dislocation, it could happen while dislocating or while the dislocation is getting reduced. Depending on that, the head would either lie posteriorly when it is getting dislocated, or when it is getting reduced, the head will chip off and come and lie anteriorly. This is the commonest classification that we use for planning the treatment, a Juret classification, which goes from 1 to 4B. 1 is pure undisplaced or slight translation. 2 is less than 30, 3 is 30 to 60, 60 to 80, and more than 80 degrees. This is what has been published in literature. You analyze the angulation, the translation. If it is less than 30 degrees angulation, less than 50 degrees translation, then you immobilize. If it is more than that, you reduce it. Try to bring it to this 30 and 50 number. If you come to it, you immobilize it. If you can't do it, then you have to go to either a percute pinning, a reduction by joystick, or with a nail which is passed through the lower end of radius. If you get a stable reduction, again this 30-50 number, below that you should get it. Then you immobilize or you go for open reduction. This is what has been said in literature throughout. What is most important is Medzov in his article said that this 30-degree angle doesn't apply for all ages. For him, if the child is more than 10 years of age, then his indication for close reduction would be a 15 degrees angulation, and for a child who is less than 10 degrees, it would be 30 degrees. Going to literature, when we come to a systematic review that was published recently, they say that the overall success rate after severely displaced radial neck fractures is around 87%. In reduction methods, it is reported as higher, that is 90%, and in close reduce, it is around 77%. What is important is we should notice that even in open close reduced fractures, it is just 90%. So even when you have been able to reduce it close without any intervention externally, we are not waiting 100% result because it's an intra-articular fracture. And the commonest problem that we face post-operatively is rotation, the lack of rotation, particularly restricted supination at the end of the healing of the fracture. When it comes to close reduction, one paper says that Ascent technique is ideal approach because of higher ROM values. The other paper says that because the radial neck is vascularized in a very typical fashion, and the nail technique kind of rotates the fragment, there are chances that the vessels might get ruptured. So again, opposing views. Coming to close reduction technique, what has been described in literature has been a Patterson method of extension and Israel method of flexion. But this method, which has been published by our own Dr. Maulin Shah recently in last year, seems to be more logical because he uses both the things. First, extension to realign the fragment, and then flexion to stabilize it and reduce it perfectly. Of course, I haven't had a chance to do this, but next time when I get a case, I'm surely going to try this method. This method does make sense. What has been practiced and has been thought as gold standard is a joystick technique. Won't go into details, but what's most important is the forearm has to be pronated maximally while you are doing it, so that the posterior interosseous nerve lies away from the entry point. Second point is very important. Either when you are doing close reduction or when you are doing percutaneous reduction, maximal displacement plane has to be understood first. The forearm has to be kept in that plane, and then we have to maneuver the fragment. The wire then pierces the skin, goes from distal to proximal. The force is first directed proximally to free the proximal fragment, and then medially to translate the fragment into reduced position. This technique has to be used, or is usually used in conjunction with close reduction techniques, wherein you push the fragment, you rotate the forearm, and apply varus stress so that you get space for the head to go inside. Coming to open reduction, when you go to the literature of open reduction, what papers say is that when you do open reduction, you are always going to get less than optimum results. Whereas the other paper says that open reduction is indicated when the head of radius is completely displaced and without contact with the rim of metaphysis. Now, this is something that I think is very important, and this is something that I have seen few cases which I have done, and probably our senior pediatric orthopedic surgeons like Sandeep sir and Viraj sir might be able to throw more light on this point. This is something that probably is going to make a difference in the choice of treatment. I would be showing it in the last slide. Now this paper speaks about surgical techniques of displaced radial neck fractures, published in JPO in 2015. They said that if there is no contact, means they have differentiated depending on whether there is a contact or there is no contact. What they have seen is in patients who have had no contact, whether you are able to do it closed or whether you are able to do it open, the results are same. You're going to face the same complications. Recent papers say that if you are going to immobilize for a lesser time, then of course the results are better. This paper from China says that they reduce it with percute method and then they fix it with nails so that they can mobilize it early. This is what I have understood and come up with the philosophy of treatment. What matters for me is whether the mechanism of injury here. Usually when it's an elbow dislocation case, then there is loss of metaphyseal contact. In a push, usually there is some metaphyseal contact remaining so that correction is easy or joystick method is available. If there is no contact, then you should be ready to open reduce. And before you do that, you should be able to, or you should be discussing with the parents about the concerns of loss of motion and other complications. Thank you.
Thank you, Viranchi, for this excellent talk, and especially about the last protocol, which you have described, is absolutely perfect. So, just one question before we go to the next talk. There are some people who do this radiocapitular wire for stabilization for displaced fractures. So, what should we say for them?
In general, literature says that it's not recommended. One, because of the micro movement that happens in the immobilized forearm, there is a chance of injury to the cartilage. And there is one paper which describes about the pin being breaking inside and not being able to remove the pin, and with the further complications. I have personally used it in one case where there was an elbow dislocation. It was 8-10 days old. Probably I would be showing it in the case. Of course, I have done it very recently, and I'm not sure what I'm going to see when the patient comes for follow-up. But it's not recommended. That's true.
Yes, sir. Viraj, sir, any comments, sir?
So you are mute.
Yeah, Viranchi, excellent talk.
Thank you, sir.
Do you have any experience of synostosis? Because couple of cases, even when you do the close reduction, still they may land up with a synostosis.
Yeah, I haven't seen it yet, but it has been said that it is more common with open reductions and not that common with close reductions. But I haven't had a chance to see a synostosis post radial neck fracture. Yeah, most of the cases that we see are they are these very mild varieties. Typical fall on outside hand with angulation of 30 or 60 degrees, which we are able to treat with closed means, either close reduction or with a joystick. This probably would apply to an open reduction case.
No, but still that possibility you have to explain why before you go for the treatment.
Yes, I agree, sir. This is one of the fractures wherein a lot of pre-operative counseling is important.
Yes, yes.
Sandeep, sir, one last comment, sir.
Hello, yeah.
Yes, sir.
No, my only comment in the whole situation is that a lot of internal fixation is being stressed. I don't think it is really required. The job of the orthopedic surgeon is to bring down the angulation to acceptable limits. You need not be perfect. You need not put wires. You need not put those nails. As long as you can be more and more conservative, your results will be more and more better, is my experience. So I have hardly done Metazoo technique ever. At the most, I will do joystick pinning, intrafocal, and I will remove the pin after 1 week. Even if I leave it in, I make a window in the plaster and I pull it out. Don't leave it too long for risk of infection or cross union, as he said. And I have seen synostosis when there is a concomitant Monteja variant. If there is a ulnar fracture at the same level like a high Hume's, then you have very high chance of getting a cross union. Isolated radial neck, I haven't seen cross union happening. So my only comment is try to be as conservative as possible.
Yes, sir. Thank you. Thank you, sir.
Great. So our next talk will be by Dr. Amit Nemade. Amit, are you here?
Yeah, I am here. Go ahead, Mandar.
So Dr. Amit is a pediatric orthopedic surgeon practicing at Nagpur. He has trained under Dr. Ashok Johri sir at Mumbai, as well as international fellowship at the Alfred DuPont Hospital in Wilmington. And he'll be talking to us about a fracture which we are, many of the orthopedic surgeons are scared of, which is the lateral condyle humerus fracture. So over to you, Dr. Amit, for your talk.
Yeah. Thank you, Mandar, for your kind introduction. And I'll start my share. Present Excuse me, I will be able to put on my camera. And thank you, MOA, for the opportunity. So lateral condyle fractures are another injury risks. So when dealing with any of the fractures, am I audible correctly?
Amit, there's a bit of
Your
lag.
voice is little breaking, Amit.
Yeah, is it clear now?
A little better.
Yes, better.
Yeah. So whenever dealing with a fracture, we have to answer a few questions. Is this lateral condyle fracture? What type is it? Is it displaced? And how do I treat them? But why at all are we discussing lateral condyle fractures? There has to be some reason that Mandar and the entire team have taken up this topic. So let's see and understand about the basics of lateral condyle fractures. It is second most common elbow fracture after supracondylar humerus. The peak age is around 5 to 6 years. It is more common in males. And the peculiarity of this fracture is that it's sometimes very difficult to diagnose. It is a fascial injury and intra-articular. There are late displacement is also common, and non-union is one of the major issues that can lead to grotesque deformities of cubitus valgus and tardy ulnar nerve palsies. Now we should know what enemy we are dealing with. So how the mechanism helps in understanding the management and evaluation of these fractures is also critically important. So fall on outstretched hand is the mechanism of injury that happens, and the mechanism described is either pull off or push off, which pushes the lateral condyle off the distal metaphysis of humerus. The fracture usually starts from the posterolateral metaphysis. It is important to understand this point because here it helps in analyzing which fracture or which view of the X-ray will give the best picture in X-ray. And this fracture extends distally into the articular surface where the hinge of the fracture lies. Now, let's see a clinical example. A 5-year-old boy who presents to casualty with history of fall on outstretched hand. On examination, he has a swelling, tenderness on the left elbow and ecchymosis on the lateral aspect of the elbow. He does not have any neurovascular deficit. So on the basis of history, it would be either a lateral condyle fracture or a radial head fracture or a supracondylar humerus fracture. If we see the X-ray, the standard AP and lateral views, there is some hairline fractures seen on the lateral distal metaphysis of humerus, which suggests that gives a suspicion that it can be a lateral condyle humerus fracture. So because this is a special fracture, we need special views. As discussed earlier, it needs an internal oblique view because the lateral condyle is more lateral and the fracture line starts posterolaterally. So this internal oblique view will give us a better picture of the displacement of the lateral condyle. Now, if we are not sure whether it is a lateral condyle fracture or not, we might need some more investigations like arthrogram, ultrasound, CT scan or MRI. I would prefer a MRI because it would give in detail about the fracture anatomy. Now, I'll come to arthrogram later in my close reduction technique. MRI is something which will give us information about how the articular hinge is, whether it is intact or disrupted. Now, if we, from all the investigations that we do, we need certain information. That is, what is the diagnosis that we have already confirmed. The X-ray will tell us whether it is a fresh or old. It also helps from the history as well. Now, here 3 important points. The type, that is, which classification does it belong to, how much the fracture is displaced, and how much big metaphyseal spike do we have. Now, there are common classification systems which are there in the literature. The Milch classification, which is more of a theoretical description, which does not help us in guiding the management, but we need to complete the spectrum for the young surgeon. So type 1 is through the capitulum and type 2 is going through the capitulotrochlear groove. The common classification that I use are the Jacob classification, the Song, or the Weiss classification. Now, if we see, there is a complete overlap of classifications. So to summarize, if we see the Song stage 1 is almost like an undisplaced type 1 Jacob. Type 2, stage 2 and 3 songs are like type 2 Jacobs, where the fracture line extends up to the articular surface, but there is not much of the displacement. And type 4 and 5 are the completely displaced types. So how do we decide the line of management? So the magic figure here is 2 millimeters. So if the displacement is less than 2 millimeters and the articular hinge is intact, we can go for a conservative management. But if the displacement is more than 2 millimeters, then definitely we need to operate such patients. Now, what does the conservative management mean? So conservative management is only for the Jacob type ones, where we can immobilize that in a cast, which can be either a bivalve cast. And the important aspect here is we need to follow them every week, serial X-rays for 3 weeks. And once we are sure that it is not displaced, then the cast is continued for at least 6 weeks or till the radiological union is seen. And then it can be removed and mobilization started. Now let's see a clinical examination, clinical case. I have inherited this case from another surgeon who has stretched the conservative management a little further, but he was lucky that the fracture united over a period of time. Coming to the Jacob type 2 and some type 3 injuries, here it needs fixation. Once you are sure that the articular hinge is intact, you can do a percutaneous spinning. Now the point here is the 2 pins should be divergent at approximately 45 degrees. One wire parallel to the joint and other going to the lateral cortex of the humerus. Another third wire can be passed in between the two going through the olecranon fossa. Here, an arthrogram can help us in assisting our reduction or whether the articular surface is intact or not. So here, if you see on the first picture, the fracture line is extending into the joint, but the trochlear alignment is perfect. It doesn't require any further reduction. So just in situ pinning will help here. Some type 2 or 3, wherein you find that the articular hinge is intact, you can pass 2 wires and then fracture heals good without any displacement. But there are certain type 3 and almost all of them will require open reduction. Although Song has described that we can try a closed reduction, but I prefer to do an open reduction to be sure that the articular reduction is perfect. So either you can use an anterolateral or a posterolateral approach. I prefer the anterolateral approach for obvious reasons that the blood supply to the capitulum comes from the posterior aspect. So while dissecting this, take precaution not to do too much soft tissue dissection on the posterior aspect of the capitulum. We can use joystick maneuvers to reduce the fracture, wash out the hematoma, put retractors on the anterior capsule so that you can see the distal humerus and articular surface in toto. And once the articular reduction is perfect, you can pin them as described earlier. Now it is important that you match the articular surface and not the metaphyseal surface, because the metaphyseal surface can have plastic deformation, which can be misleading. So open reduction, anterolateral approach, and 2 pins. So we'll solve the purpose. Sometimes if you find there is a large metaphyseal spike, you can use a screw with or without washer, sparing the physis of the capitulum. The literature says that you can pass the screw through the condyle, ablating the physis, but I prefer not to because we don't know the long-term consequences of such type of a fixation. And one wire can go parallel to the joint. So in short, if we need to summarize, once we are sure that it's a lateral condyle fracture, we can use any of the classifications to decide whether you want to do a conservative or operative method, close reduction for the minimally displaced or undisplaced fractures, and open reduction for the grossly displaced fracture. Thank you.
Thank you, Amit. That was absolutely exactly on time. And it was a very precise lecture on a very vast topic. Any comments, sir? Viraj sir, any comments about this lecture?
Yeah, I think Amit has covered most of the things very well. I would still like to emphasize on our internal oblique view. It is very important because most of the cases they have been missed because people don't take the oblique view. Just apine laterally most of the time is not sufficient. So I think that is a very, very important point. Any orthopedic surgeon has to learn that the oblique views are very important so that we are not missing the fracture. Yeah.
Amit, two related questions. One is, do you keep the wires out of the skin or bury it? And secondly, how much is the duration of K-wire placement? So how long do you keep the wires in?
Yeah, so that's a good question and a practical point here. So I keep them outside the skin only. I don't bury them. some people do bury them because that helps in, sometimes when the fracture is not uniting early, we can remove the cast and start mobilization of the fractures. So that one point of burying that would definitely help. But yet we can still, at the end of 6 weeks, when we start seeing the callus, the cast can be removed, the wires can be kept in situ, and then mobilization started to prevent stiffness. Like a protected weight bury. Maybe we can, make a splint with a flexible cast material available nowadays, or we can just break the cast and do a protected mobilization of the elbow.
All right.
Do you have any other protocol you follow?
Sorry?
You have any different protocol that you follow?
So I usually keep it buried, and I usually explain to the parents that there will be a short anesthesia at around 6 to 8 weeks, because I'm lateral condyle is one fracture where I'm not sure of union. So I always am sure of union, and then only I remove the wires. So usually at around 6 to 8 weeks is the time when I remove the wires.
Yeah.
And sometimes you may do get a pit tract infection because of excessive mobility. They don't follow the children. They don't follow, and
Right,
before union there is a migration of the pins, and therefore probably keeping underneath the skin is better idea than putting outside.
Right, sir. Absolutely. Yes, sir. Sauji, sir. So you are muted.
No, I think he is not muted. There is some directly problem with the voice.
Amit?
Yeah.
So if you can type
I wanted to ask a question to Amit. If you are conserving a fracture, how do you do the X-rays? Do you remove the plaster, do the X-rays, or do you do in plaster X-rays, or you will put a plaster and advise an MRI if you are conserving lateral condyle?
Yeah, so if we have a good digital X-ray, which almost everywhere it is available, I would first try to do an X-ray with the cast in place. If I'm not getting a good clear picture, then I won't hesitate in removing the plaster and then doing an X-ray.
All right. So for want of time, we'll go to the next talk. The next talk will be by Dr. Avi Shah. Avi Shah is a consultant pediatric orthopedic surgeon at Mumbai. He is my colleague at the SRCC Children's Hospital at Haji Ali. He is an expert in pediatric hip and pediatric trauma. He's been trained in the Vaidya Hospital at Mumbai as well as the Sheffield Children's Hospital in the UK. So Avi will be talking to you about another fracture around the elbow, which is like one of the emergencies, which is a Monteggia fracture dislocation. And let's see how he devises a method to keep the head aligned to the capitulum. Over to you, Avi.
All right. Thank you so much, and thank you so much, Mandar sir and MOA for inviting me for this talk. So as we know, Monteggia fracture dislocations are rare and missed many a times. And our whole point of this talk will be, let's see how to keep these heads aligned. So we know Monteggia fracture dislocation, the incidence is only 1.5 to 3% of elbow injuries, and the peak incidence is around 4 to 10 years of age. So everyone has heard of this man, Giovanni Monteggia. In 1814, he is the one who described this lesion. But the most important contribution for our understanding of these lesions is Professor Jose Luis Bado from Uruguay, who gave us a proper understanding of how these lesions happen and what should be their ideal management. And the classification which he has provided in 1954 has still stood the test of time. Even though there is an other classification known as the Letts classification, the Bado is still the most widely and most commonly used classification. So basically, we need to understand, to treat these lesions, one must really develop an understanding of the mechanism so you can reverse these lesions. So let's now understand the characteristics and management of the 4 Bado types which are described. The common theme which you will see in the treatment of any of these Monteggia lesions will be, one is how not to miss them. And the second is we need to correct the ulnar deformity first. You need to re-establish its alignment and length. That is the whole crux of treating a Monteggia. So now look at this. This was a 7-year-old child who had a fall and injury to the forearm. And this is the X-ray that we get. So you can see there is an oblique fracture pattern with a tension failure. there's an apex angulation, which is leading to the anterior dislocation of the radial head. So this is a Montagia type 1, and Tompkins has nicely described its lesion that usually what this happens in hyperextension, where the radial head gets pulled out by the force of the biceps, and then because the ulna is not as strong due to the force, it breaks. So now these type of injuries sometimes may not be so obvious as you saw in the previous X-ray. Now here there can be a doubt as to, is this a congenital radial head dislocation or really is this a traumatic lesion? So this was a 6-year-old. They gave an history of not so obvious fall and injuring his forearm. Here in the X-ray you can see there is an obvious radial head dislocation, but it is not so obvious and can often be missed. That is the plastic deformation which is seen in the ulna. And also you can see a calcification near the radial head. That is the calcification which you see in the annular ligament. So this line, also known as the Mubarak's line, is very, very important, as your ulna should be straight. Any deviation from it can be seen as a mist or a plastic deformation of the ulna. So this is a type 1 equivalent. So there are various equivalents that have been described in literature for type 1, and each type of lesion should be looked out for. So next is basically treating these. Close reduction has been described and is commonly utilized. So 3-point molding, as we know, to correct the ulnar deformity. Then once the ulna is straightened out, then the next part is to focus on the radial head. How to reduce the radial head? Because it's an extension injury, we need to hyperflex. So here flexion of around 110 degrees is required for the radial head to go in. So if you see here, I have reduced it with a flexion of around 110 degrees. So then is the position of the cast. So usually it is recommended to keep the cast in a mid-prone position, because here it is easier to mold the radius. If you give in full supination or pronation, it is not possible to mold the radial bone, the radius bone, and it can become difficult and increases the chance of malalignment later. So as I said, late deformities are very common in these injuries. So this was one patient where I treated conservatively. Then you can see 3 weeks post-reduction, the ulna has angulated, and again you can see the radial head has slightly subluxed. So you can see this angulation that has occurred. So this is because of the common flexors. That is one type of angulation. And the other angulation is because of the triceps, which is pulling the ulna down. So be very careful. Hence, it is recommended that if possible, if it is a transverse or a short oblique fracture, it is better to nail them either antegrade or retrograde. There is a debate where you keep the nail outside or inside. I prefer to keep it inside. So then arthrogram is also very useful to know once you're reduced, to see if your radial head is completely inside, like the arthrogram seen here, where one of my colleagues had reduced the ulna, but still the radial head is subluxed. So make sure after reduction, the radial head is inside. Plating can also be used in older children when the length is unstable, comminuted fractures, or you're unable to get reduction in a closed means. There are various barriers which may come in between, that is interpost tissue, annular ligament, bone, cartilage, and the radial nerve itself. So this is a young child which came with a Montagia type fracture. But if you look closely in the X-ray, you can also see there is a fragment near the radial neck. So there is a radial neck fracture as well. I was lucky enough to get this in a closed manner, and the child has done well. Similarly, this is a child where you can see anterior dislocation with a proper fracture of the ulna, where I've done a closed reduction and checked on fluoroscopy. Your radial head should be inside in all views. So this is another 6-year-old child injuring the forearm. So this is, here you can see there is a posterior angulation of the ulna. So this is a type 2 injury. These are more rare, but they are more commonly, they show with equivalents, that is associated with other type of injuries. So here you can see there is a posterior angulation of the ulna, and the radial head is dislocated posteriorly. So in summary, this is a flexion type of injury. So be very careful. They can present in some very unobvious manner. So here you can see, if you just look at this X-ray, you might not pick it up, but if you look at it closely, there is ulnar angulation, there is posterior alignment of the radius. So do not miss this. So treating these, the key is extension. So usually, as we know, these fractures are more commoner in children who are older, as the ulna is much more weaker to forces. So close reduction is done with hyperextension. So this was one of patients who was sent to me, and the child was treated this type 2 lesion with a flexion. But here you can see there is still an angulation in the ulna, and the radial head, if you draw the line, is still posteriorly dislocated. So give a good cast in extension and do an arthrogram is possible if you're not sure if the radial head is pointing to the right direction. So there you can see. So we do not want these type of complications in the child who had a missed type 2, because you will end up needing complex reconstructions, loss of rotations, and we might not be able to give an optimal result. So this is the Montegia type 3. So here basically you will see that there is a angulation in the lateral direction, and you can see the radial head is directed in a lateral manner. These injuries are more prone to having neurovascular injuries, that is mainly your PIN nerve. It can be injured because of a direct force of the radial head going on it, and it's an extension varus type of injury. So here again, the close reduction can be done with the reversing the maneuver by extension and as force. But these are very difficult to maintain because of the proximal nature of these fractures. So there are papers which have described flexion casting versus extension casting, but by and large, close reduction has not given as good results as you would have predicted. So this was a 5-year-old child treated with an extension cast. But if you see after 10 days when this child came back, again there is a slight displacement and the radial head is slightly sublux. So I took the child in, did an arthrogram. So you can see the radial head is not properly sitting on the capitulum, and did a close reduction. So because of high incidence of displacement in this type, IM pinning is usually recommended in most papers. So now look at this. This is a 9-year-old with an injury to the forearm. This is the most common type of X-ray which is sent to most of us by our residents or physician colleagues. So we feel, oh, this is just a simple both bone forearm, and are ready for it. But this is what the actual picture is. So this is actually a type 4, which is a rare type of Montegia injury, 1 to 11%. And you can see with the both bone forearm fracture, the radial head is completely dislocated in the anterior direction.
Can you wind up?
Yes, always get proper injuries. So it is very difficult to treat these. So just make sure to convert the type 4 into a type 1. So the radial head goes inside. So in summary, don't miss these injuries. The BADO is based on the radial head direction. Get proper X-rays. Look for the Mubarak's line and the radial head position. Understand the mechanics. And when you're treating them, monitor it closely. So this is something which was described by Peter Waters, which you can follow based on the type of the injury. Thank you so much.
Thank you, Avi. Excellent talk as always. Any comments, Sandeep sir?
No, I think it's very relevant what Avi said. One is not to draw those lines, because we tend not to draw lines and always include one joint above, one joint below. The tricky part, I think, is the one where there is plastic deformation, because you try to concentrate on the ulna and the nail of the ulna. I would rather concentrate on pushing that radial head back in and giving acute flexion so that the head doesn't pop out. If it is unstable and it does pop out, no, even doing an osteotomy is a valid option when there is a plastic deformation. There is a trick, that's a tricky area. And second one was that proximal radius ulna, where as I said, the variants where you get cross union. So you have to be very, very wary of those, and they go laterally. They tend to angulate laterally. So they create a pseudovarus, which is actually in the proximal forearm.
Yeah.
They malunite and they might come to you with a radial head subluxated laterally with a varus deformity. So those are the two tricky areas.
Yes, Viraj sir.
Yeah, excellent talk, Avi. Yeah, and the crux is here is you have to put the radial head back. Howsoever old injuries, we are getting a lot of neglected injuries, and even up to 6-7-year-old also. But still, you have to put back the radial head in, and unless until you do the osteotomy of the ulna, as Sandeep has also mentioned, you are not able to. So the crux is basically you have to put the radial head back, and the long-term results are really good. So you do the ulnar osteotomy if you get the neglected cases, and then do the angulation distraction osteotomy, or even if you are acutely are getting. And most of the time, the ligament reconstruction is not required. So if you do the osteotomy properly and the radial head is in, Most of the time, the annual ligament reconstruction is usually not required. Is that?
All right. So we'll go to the next talk.
Yes, so I have the privilege now of introducing my colleague and also one of my mentors, Dr. Mandar Agashe, who will be presenting on talking on a very interesting talk, that is the difficult supracondylars and percutaneous reduction technique. So everyone, even though everyone knows Dr. Mandar, it is still my privilege to introduce him. He is my colleague at SRCC Children's Hospital and also at Agashe Super Speciality, and has a vast experience in not only pediatric trauma but hip preservation as well, and he's quite prominent pediatric orthopedic surgeon in Mumbai. So I will now let him take over for his talk.
Thank you, Avi. So my talk is something which is different, which is difficult supracondylars. So we all know about this sort of fracture. So this is a grossly displaced fracture. When the anesthetist looks at this fracture, he immediately starts cancelling his next case, thinking that he's going to take a long time. And suddenly we finish close reduction within 5 minutes. Then we feel like supracondylars ka raja. Kabhi kabhi lagta hai apuni bhagwan hai. And for me, for supracondylars, Dr. Sandeep Patwardhan, with his fantastic experience, is like a supracondylar ka raja. We feel like him. But sometimes what happens is that there is a grossly displaced fracture. You fail close reduction. You're operating in a small nursing home in the middle of the night or early in the morning, where there is not much of assistance. And it is very difficult to do an open reduction for a very small child in such a nursing home. Then what to do? Then we have to do something which is unique, which is using a few different techniques of joysticking and other percutaneous techniques. So when we think of problem supracondylars, we think of two things. One is either they are irreducible, that is you are not getting a reduction at all, or they are unstable, that is you are getting reduction, but it is very unstable. So we need methods to achieve reduction in irreducible supracondylars, and we need methods to achieve and maintain reduction in unstable supracondylars. So let's look at each of them briefly. So what happens in irreducibility is that in a very displaced supracondylar humerus fracture, the brachialis becomes interposed, and that leads to the telltale Pahukar sign, which is seen here. So unless there is some method in order to remove that interposed brachialis, it's going to be very, very difficult. So what you do is you can do a joysticking, that is by an intrafocal wire or an intrafocal hemostat. You take a small incision in the triceps, just at the level of the proximal fragment, pass the hemostat into the fracture fragment, turn your hemostat in the fracture fragment so that it will be in the plane, and then by turning the hemostat 180 degrees, you will be able to reduce this fracture. Once this fracture is reduced, then you can fix it in the routine way, usually keeping it in the lateral view, and then do the needful with the second wire. So this is how I do it, with a small pin, with a wire, then reduce it. Then you check it on the Jones view. Usually with the help of the Jones view, you will be able to translate it mediolaterally, correct the mediolateral displacement, and then fix it in a routine manner. There have been a few articles regarding this, and this is how you can do it safely. You can use an artery forceps if you are not very confident of using a K-wire here. How do you treat the unstable fractures? Now, this unstable fracture has been described as a type 4 fracture by Leak et al. As a fracture which has a completely lost periosteal sleeve. In this case, what happens is that there is complete instability, and you have to have various methods to hold on to that distal fragment. So there are some methods which hold on to just the distal fragment of the humerus. There are some methods which will hold on to the distal fragment of the humerus as well as the olecranon, and some methods where you can hold the proximal fragment. So let's look at each of them. Option 1 is use of a joystick technique in order to manipulate the distal fragment. So this has been described very well by the original author, where you pass a wire in the distal fragment, hold it, check the lateral view so as to correct the rotation like this, correct it, make it into the correct alignment on the AP and lateral view, and then keeping that wire in place, pass 2 or 3 more wires. So this is how you do it for a multidirectionally unstable supracondylar humerus fracture. How do you hold the distal fragment of the humerus and the olecranon? So what is the scenario here? Well, this is typically seen in a flexion supracondylar. So flexion supracondylar also is a very difficult fracture to reduce because here the reduction is in extension and not in flexion, and it is very difficult to pass wires in extension. So how do you tackle that? Use a trans olecranon pin. Well, this is a fracture which was a flexion type supracondylar. So what you do is you achieve reduction in 70 degrees of flexion and pass a good 1.8 or 2 millimeter wire through the olecranon fossa, and through the distal fragment into the medulla, like so. And then look at the AP view, correct it on VAR as follows, because it's just going to be an intramedullary wire which you are able to move, and then fix it in the routine manner from the lateral side. This K wire should not be very thick. It should be thin enough to allow these 3 wires. And once these wires are fixed, then you can remove the transolecranon wire and then fix it in the routine manner. The third option is that of the proximal fragment. Now, this proximal fragment fixation holding is required typically when there is an issue with rotation. So whenever there is a rotational malalignment, think of manipulating the proximal fragment. How do you do that? Again, the joystick method. Here, all the 3 methods, the joystick word is used, but the implications of the word joystick are completely different. Here, you use a K wire in order to correct the rotation of the proximal fragment. So what you do is you pass the wire through the proximal fragment just above the fracture site, correct the rotation, and once that rotation is corrected by seeing the hourglass of the distal humerus, you fix it in a routine manner. So this is a video which has been kindly provided to me by my colleague Dr. Venkat Das from Ganga. So you can see that there is significant rotational malalignment. So what he has done is passed a wire in the proximal fragment, derotated it, corrected the rotational malalignment like so, and then keeping this in situ, fixed it with 2 or 3 K wires. So once there is a rotational malalignment, think of using the proximal fragment to manipulate it. See to it that you are not too proximal, otherwise you can injure the radial nerve here. Thus, to reiterate, if there is a coronal and sagittal plane malalignment, you can use the distal fragment. If there is a rotational malalignment, you can use the proximal fragment. Thus, take-home points, think of when you are not getting a good reduction, think whether it is an irreducible fracture or whether it is an unstable fracture. If it is an irreducible fracture, we should have a means of achieving it, which is the joystick reduction. If it is an unstable fracture, we should have a means of reducing it and holding it reduced, thus coronal malalignment by the distal fragment and rotational by the proximal fragment. Thank you very much.
Mandar, very wonderful presentation and clearing the doubts about the very interesting supracondylar fracture.
Thank you.
We have learned so many times from Sandeep Patwardhan about this thing, the cardboard methods and so many other things.
Right.
But this is something different, that from the posterior tricep we manipulate it and trans olecranon K wire for stabilization of reduction.
Right.
That's what I learned today.
Thank you, sir.
Mandar, if I can just ask a question here.
Right, sir.
Sometimes we have comminuted fractures which make them unstable. Like you said, one is irreducibility, second is the comminution. So in case of comminuted fractures, do you have any advice to enhance fixation, or what would you advise the listeners, because we wouldn't want them to end up with an unstable fixation?
Yeah. So I think one of the things is that we can add another wire. So my typical type of fixation is 2 wires, but sometimes we can add another wire on the lateral side. The other thing is which you also had, in fact had explained to me a long time back, is that see to it that the reduction is in valgus. Everything else is unimportant. Just have a valgus reduction. And once that is there, you are home free. So even if it's a comminuted fracture, you're not going to get an end-to-end reduction. See to it that you have a valgoid reduction, and that's it. That is the most important thing.
That's the point I just wanted to highlight for most of the people is that after your fixation is over, also look at the forearm clinically. Don't look only at the X-ray.
Absolutely.
It should be in 7-degree valgus, and if you feel that the need to pass a intramedullary wire from the lateral side, and when you bend it, it gives that valgus force.
Correct.
And I would also then cast it in a little extension rather than 90 degrees, because I want to see that valgus. And then you can always convert it to a 90-degree cast in 15 days.
Yeah.
But as far as you are close, I think results are always better than trying to open, especially when it is complicated.
Absolutely.
Am I audible?
Yes, sir. Savji, sir. Yes, sir.
I just want to ask one question to Mandar. If there is a buttonholing, suppose,
Yes.
displaced fracture and buttonholing, still you will do close?
So, sir, buttonholing, you have to first do the milking maneuver, which usually helps to pop out the brachialis from between the fracture site. Once that is there, usually we should be able to get a good reduction. In case it is not possible, then you can do that intrafocal technique, where you can pass a hemostat and then reduce it. The last option is then opening up. The open reduction, again, has to be reserved for very, very, very rare situations where there is a neurovascular insult. So in case there's a pink pulseless hand with a median nerve palsy and you are not getting a reduction, in which case it is safer to do an anterior open reduction. So anterior open reduction, where in this case is quite in the sense it's right there. So all you have to do is take a L-shaped incision centered around the cubital crease. The fracture fragment is usually subcutaneous. Just you can palpate that. Once the fracture hematoma is done, and just with a sweep of the finger, you can put that fracture fragment in, and that will be enough. So again, open reduction should be reserved only for very, very less situations where there is a neurovascular injury or where it is just impossible for you to reduce it.
Just one point, Mandar. Viraj sir, I guess he has a technique, by using a suction tip.
Yes.
Viraj sir, can you please enlighten us on that?
Yeah, Mandar, just extension to your explanation to Dr. Savji sir's question. So basically the crux is you have to reduce the compartment pressure by taking out the hematoma.
Correct.
So by any means, so we have used the blunt suction tip. So where we put it just anterior lateral to the midline, I mean just so that we are not damaging the neurovascular bundle. So that suction tip, blunt suction tip helps in taking out hematoma, as well as it acts as a joystick to stabilize the fragment so that we can reduce it with the help of this. This is just the counter, so we can stabilize the distal fragment. So I mean, any method by which the surgeon is comfortable can be used. Like one can use even the hemostat, one can use the suction tip. But the crux is most of these injuries still can be managed by the close technique if you take out the hematoma. Yeah.
All right. So we'll go to the cases. I think we are right on time. We'll have a few cases and it will be a quick cases. So what we'll do is the presenter will present. We'll have a brief interlude in between. We'll have the panelists as well as the faculty to have quick comments. And then we'll go ahead about what was done for this case. So we'll have the first case by Avi, which is another difficult scenario, which is a neglected elbow dislocation in a child.
Thank you so much. So I'll just start off my case. This was a 9-year-old girl who presented with an injury to her left elbow around 5 to 6 months back. No treatment was taken. So the main concern they came was the child was unable to lift any objects, restricted range, and had difficulty with her daily living, and she had a deformity in her elbow. So this is her clinical pictures where you can see there is a change in the carrying angle. Her forearm, she keeps it always in an internally rotated position, and from posteriorly you could literally see how taut her triceps muscle was. And clinically she had a flexion deformity of the elbow of around 60 degrees with further flexion only just up to 90 degrees. And she had good supination, but her pronation was restricted. and her also elbow, if you can see the shape of the elbow was quite not maintained. So at this point, I know Viraj sir and Sandeep sir have a lot of experience in having such kind of neglected elbow cases coming to them. So I'd just like, sir, first Viraj sir and then Sandeep sir, to give, as soon as these kind of patients come to you, what comes in your mind and what is the planning that goes on in your head for the next steps? Viraj sir, if you can just unmute yourself.
Yeah. Yeah, Avi. So if you are sure that it is a neglected elbow dislocation, I would still go ahead for the reduction. And I usually take the two approaches, the medial and lateral approach, right? So this is now the X-rays classically that there is a dislocation. It's a most common, that is a posterior dislocation, right? So we take the medial as well as the lateral approach, just protect the median now, the ulna now, and then we have to go into the joint by doing the tricepplasty. So tricepplasty is a crux to go inside joint, so that circumferentially we are seeing everything under your vision. Reduce it, and here another important point is I always ask the GA to be given, because if you try to do these surgeries in just under some kind of blocks, most of the times the reduction is very difficult. And many times I keep the even blood ready because a lot of blood loss is there. So these are the important points. And then we mobilize it a little faster. So once you reduce it, we just give the slab and we just teach the patient to get the slab removed and then again move it. So the crux is, if you mobilize a little faster, you will get a good range of movement.
Thank you, sir. Sandeep sir, any comments from your side? Would you do the same or anything different? Any other imaging?
No, I think my approach is completely contrary to what has been said by Viraj. The first thing being that most of these neglected elbow dislocations would have been massaged. And I'm extremely wary about newborn formation in the triceps as well as intra-articular. And I don't think by collateral approach you can lengthen the triceps. Unless you lengthen the triceps, you cannot get reduction. And if you struggle with reduction, you will crush cartilage. So I will go with a midline posterior approach and first do a triceps plasty to elongate the triceps, which sometimes is quite a lot, without which you will never get the reduction. Second is, depending on the duration, always warn the family that the purpose of surgery is to make the elbow stable for a better forearm and hand function and not to restore elbow range. It's more for stability than mobility. And we cannot ever promise them good range. So I do not hesitate to even transfix the elbow for a couple of weeks with small K-wires till the triceps heals. And then I will start mobilization only after 3 weeks. And if they get 30 to 70, I am happy. And once the anatomy is restored and the elbow is stable, I can always go ahead and do another arthrolysis after some time. So I don't think one surgery will suffice. But having said that, it is very important to restore the anatomy of the elbow for better hand and forearm function and not for the elbow. You need to give it a stability.
Absolutely agree with you here. So this one was a distal, and you could even see the part near the coronoid looked quite flattened. So I was even hesitant. Was the history really 5 to 6 months, or was it even more, looking at the type of injury it was? Couldn't see any piece. Unfortunately, I did not have the opportunity of getting a CT scan, which sometimes may be required, not always, depending if you're suspecting some other type of injuries. So I pretty much did what Sandeep sir mentioned right now. So I went through a lazy S approach from the posterior, identified the ulnar nerve. I first tried the triceps pairing to see if it goes in, but the elbow did not even want to move. So I had to do a triceps plasty. So I did pretty like a U-shaped flap, removing the entire triceps from the olecranon and then reducing the elbow and then suturing it back. So this was, once I moved the triceps, I got a good reduction. And then I was just assessing the stability. There was a little mismatch of the shape of the radial head to the capitulum, but the main is we have to put it inside and we check the stability. So post-operatively, as sir said, I was a little hesitant. So I did put a single wire just to keep it in place, because I did not even trust the child as well. And at third week, I did remove the wire and we started range of motion exercises as soon as we could. So this is her now at around 3 months. We got quite good, quite decent range, around 20 degree of deformity still there, but up more than 120 degree of further flexion up to there. The elbow is stable. She's able to do all her routine activities and now able to at least lift objects with that arm. So comparatively, the family is still happy. But as sir said, I have let them know that later on there are other risk and stiffness, and she may not require some other procedure. So just to go literature, as such, pediatric elbow dislocations, there is not too much literature out there. There are a lot of sporadic case reports. There are a lot of adult literature out there. So from whatever I found in the last 5 years, I'll just put a summary. So basically, all of them said the best results are if the child comes to you before 3 months of age, when you can do the reduction. You can reduce them even up to 2 years with decent results. It's the results are much better if it's a pure dislocation in comparison to dislocation with complex other type of fractures which have malunited or which were present. Various approach, as you can see, our two surgeons, Dr. Viraj had a different approach and Sandeep sir had a different approach. But there are various approaches which are mentioned depending on what works in your hand. Some people have even mentioned about fixators. The crux is to get the joint in for stability, early mobilization as soon as possible, and also explain them the risk of stiffness and sometimes even redisplacement because all the ligaments have been injured at that time. And a lot of them have described that post arthrolysis, sometimes the results are not the great, but as long as you have a stable and decent elbow, they are quite functional. Thank you so much.
Thanks, Avi. We'll go to the next case. I'll be sharing my screen. I think for want of time, I think we'll have someone else also. So I'll skip one of my cases. I'll go to the third case. Just one second. All right. So this is a very confusing case which I had to manage. So this was a young 9-year-old boy, had a history of injury to his elbow 4 years back. He had come to me and he had come to me with x-rays from somewhere else, and he had a plaster on for about 3 weeks, and he had then disappeared for about 4 years. And then now has come back with restricted movements and a deformity in the elbow. He has restricted forearm flexion and supination, and the characteristic history which he gives is that he has significant pain when he flexes and supinates. He doesn't have much of pain when he's pronating and flexing, but he has severe pain when he flexes in supination. And there's a palpable bony block in the forearm when he is supinating. So these are the x-rays. As you can see, in supination, there is a radial head which is popping out. So there is a deformity of the proximal radius which is causing it to pop out. But there is also a Mubarak's line which is positive. So there's a plastic deformation of the ulna as well as angulation of the radius. So Viraj sir, if such a case comes to you, what will you do, sir? What is the planning that we will do?
So Mandar, this is kind of Monteggia variant. There must have been, in addition to the deformation of the ulna, or maybe the fracture at that time, we don't know because we don't have the injury film over here. So there would have been the fracture of the radius as well.
Correct.
Right, and that is why it is causing the deformity of the proximal ulna as well. So in such cases, I think maybe just doing the osteotomy of ulna may not be sufficient. Absolutely. You might need to correct the angulation of the proximal radius as well. Then only you might be getting the stable radial head reduction.
Absolutely.
So definitely it's not very common, very unusual case. So I think in this case, I would go ahead for the correcting. I mean, in addition to the angulation osteotomy of the ulna, I may do the osteotomy of the radius as well. Absolutely. And see the stability of the radius in that case.
Sandeep sir, any comments, sir?
I think this is primarily a rotary malunion of the proximal radius, which is why in pronation you can see that the capitulum and the radial head line up, but in supination it's angulated and the radial head seems to be out. So I think it's an angular deformity with a malunion, rotary plus angular malunion at the neck radius or just below it. So you have to tackle it at the apex with a osteotomy. And one way to avoid the ulnar osteotomy could be to shorten the radius at that point.
Correct.
So you can try shortening and plating when you're doing your correction, or then you lengthen the ulna if it is not sitting in nicely.
Absolutely.
But either way, the radius shaft proximal has to be tackled with careful dissection of the posterior intrustus.
Absolutely. So we also did 3D planning. This was the model which we did. So as you can see that there is an angulation of the ulna and there is an angulation of the proximal radius at the level of just below the radial neck. So it was in fact a combination of probably a type 1 plus equivalent with a type 4 Montegia. So what our plan was as Viraj sir and Sandeep sir said, corrective osteotomy of the ulna of the radial neck with or without a flexion distraction osteotomy of the ulna. So I decided to do it with a nail. So this is the entry of the nail. I brought the nail till the proximal radius and then opened the proximal radius using the Boyd's approach. Carefully dissected it out, and you can see that this is the level of the osteotomy, and the proximal radius had gone up. And I did the osteotomy. I passed a wire to hold it, did a close wedge osteotomy of the radius, and straightened the radius. So thus I created a combination of type 4 and a type 1 Montegia into just a type 1 Montegia, after which I did a flexion distraction osteotomy of the ulna, like a routine missed Montegia, after which the radial head sat back in place absolutely well. So this is in all views, the radial head is sitting back in place. The angulation of the radius has been corrected and there is a flexion distraction of the ulna. This is the postoperative X-ray. This is at 2 months. This is absolutely, both the osteotomies are completely well healed. The radius is aligned well with the capitulum here. He started having fairly good range even at 2 months. This is at 2 months. And this is about a year post-op, showing absolutely excellent alignment of the radiocapitular joint in all views with good healing of the osteotomies. And he is absolutely comfortable. He doesn't have that pain which he had when he used to flex. And the patient is also very happy. Thank you.
Very well managed, Mandar. Very well managed.
Thank you, sir. We'll go to the next question, next case. We have Dr. I think Sameer has his case.
Yes, Mandar. Yes.
Yeah, Sameer, can you show your cases?
Yes.
I think Sameer is frozen.
Yeah, I think his network has.
How many times do you apply just a plaster? How many times do you?
Sameer, can you go back to your first slide? I think we were not able to hear you during that time.
Yes. This is the first slide, Mandar. Hello,
okay.
Mandar.
All right.
Yeah, hello, Mandar. This is the first slide. Yes.
Okay.
Okay, so this is a child, a 10-year-old with a severe swelling. And I would like to ask the panelist, how frequently do you do an MRI if you see a swelling, but on an X-ray you don't see a fracture? And would you just go in with a plaster, or what would you advise? So in this case, I've got a child with a swelling with a nearly normal looking X-ray. Anyone, Sandeep sir or Viraj?
Yeah, if I am in doubt and I don't have the diagnosis, there is no harm in going ahead and doing the MRI. But before that, I would take, few oblique views on I will confirm whether there is, I am not dealing with any lateral condyle which I am missing on the APN lateral views, or might be sometimes maybe a fracture of just the coronoid process or like something. So I may take little further views before going or jumping for the MRI. And if I'm not sure, then there is no harm in going for doing the MRI. Yeah.
Very good suggestion. Actually, this child was treated with a plaster, and then 3 weeks later, this was the X-ray. Any takers for this case? So this was a 3-week-old neglected fracture. So what would you like to do in this case? Yes, Viraj, yes, Mandar, what would you like to do?
Yes. So these
are the MRI and the CT scan.
So this is a displaced capitulum fracture. This definitely is an intra-articular injury, and this definitely requires fixation. So not a very good injury to have as a patient as well as for the surgeon. But
yes, yeah, I know that. Yeah. So there's a classification system for this, and it has been divided into type 1 and type 4. Type 1 to type 4, and looking at this classification, probably ours was type 1. So there are two approaches. Either you could go a lateral approach or anterior lateral approach. So we decided to go. We isolated the posterior interosseous nerve, and what we used is an Arthrex PLLA material absorbable K wire along with a headless screw in this case. So this wire gives excellent protection, screw and a wire. We preferred this approach because we were expecting some amount of malunion. I mean, so going dead lateral would have been very difficult. So we thought that probably we'll go anterior. And unfortunately, this child developed a posterior interosseous nerve palsy, but the child recovered over a period of 6 weeks. And this is the range of motion of this child at 6 months. Thank you.
Excellent. So we'll have one comment by Sandeep sir, if possible.
So this is one of the trash lesions. If you have a swollen elbow with an innocuous looking X-ray, additional investigation is mandatory. And capitular shear fracture is one of the described trash lesions, and all of them are usually intra-articular and will need fixation. So for all the people who are listening, if you have a swollen elbow which looks disproportionately swollen and the elbow X-ray looks normal, please get additional imaging in form of an MRI at your place, arthrogram and ultrasound depending on experience.
Yeah.
So MRI will at least give you a good diagnosis, so that if this could have been intervened early, then probably the time would have been saved and better range would have been achieved.
All right. So we'll go to the next case, similar but probably a slightly dissimilar one. This was a 15-year-old boy, a big boy. गांव में गया था, बैल को चलाने गया था और बैल भाग गया. That was the history. He had a sudden pull by that bell, and this was the X-ray done there. This was reported as normal, and he was treated in a slab. He came to me after a month with severe stiffness and anterior elbow pain. He had pain and tenderness over the anterior elbow on mobilization and has a palpable mass over the lower third aspect, over the anteromedial aspect, in fact. And range of motion is about 40 to 90 degrees. And this is the X-ray. Viraj sir, I can see your eyebrows going up. So what do you think we should do? What do you think is this?
Mandar, is it is that a malunited fragment, or is it massage, the myositis?
So initially, the story is that this guy is the son of a general practitioner. So he sent me this X-ray. I initially thought it was myositis. But he also sent me this old X-ray in which also there is this fragment. This is the day 1 X-ray. So this is what it is. And you can now make out that there is something which is missing here. So we got a CT scan done, which showed a huge capitellar piece. The capitellar fossa extending into the trochlea. So this is a type 4 injury. And you could see that it almost in the lower third humerus, the capitellum had gone up. So now what should we do? Sameer, you just presented this case of capitellum. What will you do?
It looks a very complex case. I don't know, probably. What is his range of motion currently, Mandar?
He's about 40 to 90, but he is very painful around the elbow. He is not very comfortable in that range.
Probably I'll discuss with the parents and then think about fixation, but I don't know. It's going to be really tough. Probably take a help of a hand surgeon along.
Absolutely. So again,
you really think an hand surgeon has better skills than you? When in doubt, call a colleague pedipod.
Exactly.
Don't call somebody who has never seen this just because he labeled himself hand.
But it is painful, so I think we should go ahead with the treatment.
Exactly. Especially because we found that there was this big chunk of intraarticular piece which was completely missing. So the pain is going to increase, in fact, if we keep it like this. So what I did was an anterolateral open reduction, not an anterior one. Again, there was a big debate about what we should do. So I did an anterolateral open reduction with fixation with a headless cancellous screw. And there was on table after induction, there was a significant valgus instability with in this case. So lateral approach. This was the capitellar fossa, and the capitellum was right up. So slowly with the periosteum elevator, I tried to do it as less traumatically as possible. Slowly tried to bring that entire capitellar fragment down, and then once it fell back in against the radial head, it was quite stable, and I fixed it with 2 headless cancel screws. This was the on-table picture. You can see that this is completely well aligned. 2 headless screws here. This, unfortunately, I don't have a longer follow-up. This is the immediate post-op, and this is about a month down the line. You can see that the head has been well aligned, and the reduction seems fairly okay. I'm still waiting about how I already mobilized him. I'm hoping that they should do well so that I can present in the next iFix.
Excellent result, Mandar.
Yeah.
Thank you, sir. So, any comments for the 2 capitellum cases? Sauji sir, Gadegone sir.
It was very nice case.
Yes. We'll go to the next one, which is on radial neck. So we'll again have Dr. Sameer Desai will be presenting his case of radial neck fracture.
Yes, Mandar. Okay. 1 second. Are you able to?
Yes, we are able to see.
Yeah.
See the screen?
Yeah.
Are you able to see the shared slides, Mandar?
Yeah.
Okay.
Yes.
So this is a case of a child with history of fall, and you can see there's elbow dislocation, and you can see something else. So anyone, Avi, what do you feel?
Yeah, that's a radial neck fracture which is completely displaced.
Correct. Yeah. So this is a Jeffries type 2. I'll just go quickly because of want of time. And there's a persistent posterior bridge linking the radial head and the metaphysis. And so there are reduction maneuvers that have been mentioned, one with a joystick and one with a closed method. I don't know. I have had just an experience of 3 or 4 cases, but I've never been able to reduce it closed. What about the panelists?
So there are 2 things in.
Have they been ever able to reduce it close? What is the experience?
So there are 2 things in radial neck fractures. One is this method, and second is the one described by Moulin. I have never been able to be successful in both these methods.
I was successful in one of the cases I showed, the Montegia, which I did, and I was lucky enough it fell in place. Sometimes it happens, but other than that, I have never got it in place with a closed maneuver.
Yeah, neither did we. So we went in, opened it by the lateral approach, Cocker's approach, and put in a K wire. And this is the range of motion at 3 months.
Very nice.
Thank you.
So I think a teaching point here is that if you see the radial head fragment posterior, it means that there is some issue with it, and you can't just go ahead and do an intrafocal kind of thing. So this is a different mechanism. I had one experience where in this the key point is that the amount of contusion which is there here is much more than in a routine radial neck fracture. Usually in radial neck fractures, the contusion is not much. Here, the entire elbow is completely swollen. And that I think is a pointer to the fact that this is something other than just a run-of-the-mill radial neck fracture.
Sameer, have you ever tried Ishmash for the reduction? Tried sometime. Ishmash bandage. Sometimes it helps.
Correct.
So a final comment by Dr. Patwardhan, sir. He has to leave. Are you there, sir?
Yes, yes. No, the only thing is through all these cases, like you have rightly said, supracondylar and lateral condylar are not the only fractures. All these articular fractures where there is a fragment missing, the head lying out, a piece lying inside, or a dislocation which is unreduced, or a missed Montegia. People should realize that in children, no, we should not leave them alone saying that things will remodel and they will adjust and they will adapt. All that doesn't happen. The articular pieces need to be put back. There is no reason to get scared because you will lose range. But you must restore the anatomy, especially osteochondral fragments. That is absolutely mandatory. The complications can be dealt with later. So it's important, the message should go out that look more critically to pediatric elbow fractures rather than leaving them to divinity. God doesn't help.
Absolutely. True words of a stalwart. Thank you very much, Sandeep sir, for
Thanks for having me. Thank you, Gadegone sir, Sauji sir.
Thank you, Sandeep sir. Thank you.
Thank you, sir.
So we'll go to the next case, which is by Dr. Viranchi, again related to the radial neck.
Hello. Yeah. Mandar?
Yeah, you're audible.
Okay. So I'm planning to show two cases in tandem so that the whole concept becomes clear. One case is courtesy of my partner, Dr. Vishal Chanda. Other is mine. So these are two cases, a 6-year-old female, typically of history of fall on osteochand, and this is an 11-year-old male who had a fall from two-wheeler. As has been shown by Sameer, the case on the right appears to be a typical dislocation case where there is a fracture also with the radial head displaced. Now, panelist and Viraj sir, Gadegone sir, my most important question is mechanism important when we decide the planning of the surgery? Do we investigate in any other way at this stage? How urgent should we plan the surgery? And any specific preoperative counseling that has to be done to the parents? Viraj sir.
Yeah, Viranchi, there is no question that you have to start a treatment as earliest as possible, right? If your X-rays are adequate enough and giving you the adequate information, I don't feel you should go for any further investigation. The cases, what we have discussed in the past is fine, but the two X-rays, what you have shown, in both the cases, I think the injury, mode of injury as well as the fracture is clear. Yes. So you should go ahead for the management as earliest as possible, because you delay the things, maybe the reduction you may not get as anatomical or maybe as good reduction it is possible. So the treatment has to be as early as possible. And I would still try to go ahead and do the close reduction, maybe using some additional thing like HMAR, bandage or like something. If still not coming, I will still go ahead and do the joystick maneuver. So many times, if the reduction, maybe I have fixed even the reduce the 3 weeks old injuries also. And in these cases, the joystick wire is not sufficient. So sometimes I have just put the wire inside the radial head, and with the second wire, then I may just lift it so I may sometimes use 2 wires as a joystick maneuver to reduce the thing, and then I will just put the nail like Matthews technique. It's like that.
Okay.
Yeah.
Anybody else? Mandar, any comment? Sameer, any comment?
Yeah, absolutely agree with Viraj sir.
Okay. So what has happened in radial neck fractures is this article published in 1998, where they advocated conservative treatment, to the article published in somewhere in 2016, where they said that surgery is also good. We have come to papers who now say that, okay, you are also do open reduction, but be pragmatic and try to get a anatomical alignment so that the movements are restored. Basically, because it's an intra-articular fracture, we need to have an anatomical reduction if you are going to do it open. So this was other view. The girl has a metaphysical continuity seen, though it is more than 60 degrees. And this elbow reduction, after reduction of the elbow dislocation, X-ray was taken. The head seems to be lying completely anteriorly. Now, in these 2 cases, probably on the case where it's a fallen oxus hand, the procedure is simple. That you try closed, you do open. We have already discussed, as Sandeep sir said, he doesn't do a mezzo technique. Percute reduction is something that we all do as a gold standard technique with a K-wire. Viraj sir, implant that you use routinely, and for how much time do you immobilize? Because there is one paper which says that duration of immobilization also matters when it comes to final range of motion.
So if the flexible nail is not available, I will simply use a long K-wire. Many of the times we use a simple long K-wire, and by using the Matthews technique, I will just stabilize the radial head.
But you always do use an implant. You won't
Yes, I always fix it so that there is no second chance in these cases, right? So I will always fix it, and I will mobilize as early as possible, even at 3 weeks. Okay. So yeah, as early as, and even I would take out the implant also as early as possible. Maybe like say 2 months or 3 months or like, so I will take out the nail or the wire which I put.
Okay. So
the X-ray on your right, you are going to need open reduction, isn't it?
I was going to come to it. Basically, this was done by Vishal. He did it with the percute technique and intrafocal pinning. Fixed it additionally with one more K-wire. This is her X-ray at 3 weeks, and then this is her X-ray at around 6 months, and this is the range of motion at around 6 months. What we have also observed is that supination always is a bit restricted. They do get good pronation, but at the end, still they might have some supination restriction. I'm not really sure why it is there. I couldn't find any convincing reason in the literature, but these kids tend to have loss of supination at the end of the rehab treatment. Any comments about that, Viraj sir, Mandar, Sameer? Why supination is lost and what pronation is not lost?
Maybe, Viranchi, I personally feel there might be some degree of the synostosis which is happening, particularly even if you are trying to do the closed method, but if the patient is presenting you quite late. So I have seen a couple of cases where the good reduction I achieved, I mean, there was no open reduction. I could get the reduction only with the help of just by the joystick, but still some degree of the synostosis might happen that may be giving to the restricted supination. That is the reason when the talk was started, I just mentioned that you have to counsel the parents.
15 minutes वेळ आहे म्हणा.
Yeah. Okay. Any experience, Dr. Gadegone sir, or maybe Dr. Sauji sir?
Sauji sir.
Sir, I have no experience of this thing.
I also don't have much experience.
Gadegone sir, he's seeing a lot of trauma. He's one of the very senior orthopedic surgeons in this area.
No, but I have not seen this type of injury.
Sir.
So one of the things I think what should be done is that even when you are putting those wires, I think we should see to it that they don't go beyond the cortex too much.
Okay.
I think in one of the X-rays you could see that the wires had gone beyond the cortex, and that is a cause for some amount of newborn formation in the radioulnar space. So that is one thing where you have to be really careful about that. The second thing is that the method of the position of immobilization is also very important. So in any radial neck fractures, I always, in fact, most of the casts which I give is always in supination. So parents tolerate, the kids tolerate loss in pronation much better than loss in supination. Loss of
You can compensate your shoulder, right? Correct.
So position of immobilization is also very important. But great case overall.
I agree. Yes. And yes, coming to that case, Sameer, I tried to do a percute technique, but I was not able to get hold of the head. The head was just slipping from my K-wire. I tried for around 10-15 minutes, was afraid that I might injure a nerve, the PI in that scenario. I had to open anterolaterally through the Anconius and ECU approach. Even when I opened it, I was not really able to get hold of the head. It was just lying freely in the elbow joint. I had to really push it from outside with one finger, hold it with two fingers from inside, and then try to slowly pull it back into the space and put it. With some pronation in the forearm, it matched perfectly. At that point, I was doing it at a small nursing home, and as Sandeep sir said, no, it was sitting so perfectly that I was tempted it. I shouldn't fix it, but as Viraj sir said, there is no other chance. So what we did was, So what we did was we fixed it with two K-wires. One is transcapitular, which we usually don't do, which is not recommended. And we also fixed that small fracture of the olecranon so that his elbow becomes stable. We have done this case very recently. It's in this one only. So long-term result is awaited. But we are afraid about AVN because it was just lying free. So I'm not really sure about the blood supply. Once I get a long-term result, then probably I would be able to share it. Not a very routine case for me. Elbow dislocation with a fragment lying completely freely in the elbow joint, a radial head fragment.
But excellent case. As you said, sometimes
Viranchi, it's usually very difficult to bring it in its position. So you've done
yes.
Sometimes it is extremely difficult for, sometimes we are forced to put a radiocapitular wire, especially when it is associated with a dislocation or when the piece is lying absolutely free. So let's hope, again, as I said, let's hope that we see this case in the next year in either Posicon or IFIX or something.
Yes, in this case, I hope Divinity takes care of the case now.
Great.
Yes.
So, Dr. Manoj, do we have time for one short case or should we wind up? You are muted.
Mandar.
Yeah. We can take one more case. Yeah.
Okay. I think Amit, are you ready with your case?
Yeah, I am. Can you hear me?
Yeah.
So this is a short, quick case considering the shortage of time. So I have a 6-month-old infant who had a history of fall from bed a month ago. Following, he developed swelling and decreased movements in the elbow. Before he came to me, he was managed in a slab for 2 weeks, but in view of persistent swelling and pain, he was sent to me. On examination, there were no signs of inflammation. The child did not have fever, and his lab parameters were normal. And this is the X-ray that he presented to me with. So, Viraj sir and Mandar, any suggestions on this X-ray? What we can conclude on a diagnosis or something?
Yeah, Amit, when there is such a severe swelling, as you can see that even on the X-ray, there is a significant amount of soft tissue swelling which is seen. And when there is no specific history of trauma, or if the history of trauma is not very significant, it's always safer to image the child.
AV platform so क्या करें? अच्छा, loose body.
So here we have an MRI. So except for that, like you rightly pointed, there was significant swelling in the elbow, which showed that there was some effusion and synovitis component in there. So we got an MRI done. So this was the MRI, which showed that there is significant edema around the muscles, some effusion there. And along with that, it showed some loose fragment lying anterior to the capitulum. So any suggestion or any suspicion here on the MRIs? So the radiologist also got a CT done. And if you see the X-ray, let me go back to the X-ray, original X-ray. This is a 6-month-old boy, yet he has a small, ossification in the condyle, the lateral condyle. So do we see lateral condyle ossification so early?
Ideally should not.
So that's the reason we got an X-ray of the opposite elbow also, which did not show any ossification center on the left elbow. But if you see the MRI scans, the lateral condyle looks okay. It doesn't look fractured or anything. So what would be the next plan now? Mandar, Avi, any suggestions?
Well, looking at everything after discussing, if there are no other injuries and things, then most probably the loose body is what is causing the inflammatory response. May have to think about removing it if that is the only cause.
With any history of, neonatal period, any kind of sepsis or infection to elbow or like something?
No, the child was perfectly normal till he, presented with this history 2 weeks ago. And except for pain in pronosupination and some flexion deformity, there were no local signs of inflammation.
Very rare to get a loose body type picture in this kind of age group.
Sorry?
Very rare to get this kind of a loose body in this age group which you are talking.
Any injection, any antibiotic at a time of neonatal period, kabhi elbow mein de to.
So after the trauma, the child visited the orthopedic surgeon straight away, and then he was just put on some anti-analgesics like paracetamol, and a slab was given. So considering that he was too young for a lateral condyle ossification center, I thought maybe it is just a variation. It has appeared too early because theoretically it can appear by 4 months. It's some paper that I have read. The other reason that was against a fracture in the lateral condyle was the margins was smooth. So I thought like maybe it's just and we have an MRI which shows that there is no condyle fracture. So here I kept a differential diagnosis of like already there was a loose body, and the other possibility of infection is also has to be kept in mind. So my plan was to examine him under anesthesia, do an arthrotomy, which would obviously wash out the joint, and also try to remove the loose body and take a synovial biopsy to confirm my diagnosis. So I did an intraoperative arthrogram after aspirating the fluid which was sent for culture and other things. Maybe this decision was more biased because if you see the arthrogram, you can see some filling defect seen on the anterior aspect of the capitulum. So I did this more out of academic interest and as a learning point. So after opening, the standard lateral approach was taken, the elbow was exposed, a thorough lavage was done, and then what came out of the joint was this loose piece, which was lying exactly anterior to the capitulum that was seen in the MRI. So on inspection of this loose body, it was actually not a granulation tissue or anything. It was a proper synovium with some soft to firm attachment of another piece at the other end. I tried to explore the joint or see if I could find any cartilaginous defect, but because the baby was too small, I really couldn't find defect anywhere. So once this piece came out, thorough lavage was done, and then I closed the wound over a mini vac. And this patient has kindly sent his recent pictures. Now, if you see his recent pictures, the X-ray is not much different except for the persistent swelling. In the initial post-op period, he was recovering very well. If you see now, he has some flexion deformity, but he is able to actively flex and use the extremity to almost some degree of limitation of flexion. Now, he is yet to come for follow-up. But what bothers me is the flexion deformity and the persistent synovitis inside the elbow. So the take-home point here is there are certain elbow injuries which can present to us, which can really stump us, and it can be very tricky case. So it's always better to investigate thoroughly before we jump onto anything, because although infection is common, but these rare things can happen. Any experience, Mandar or Gadegone sir, Sauji sir?
Amit, I
Have
have a
you
doubt.
said this for histopathology?
Yes,
Histopathology.
Amit, I will. What was the
Exactly.
histopathology report? And you have to rule out infection or probably tuberculosis. You don't know.
Yeah, infection,
Yes.
tuberculosis, and
Histopathology.
rheumatology.
Yeah. So let me go back. So histopathology was sent, and it was reported as just an inflamed synovium or synovitis. They could not find. The culture was negative, and there were no bacilli seen in the synovial fluid.
I mean, did you rule out rheumatological causes, because that could be one of the reasons why the still persistent synovitis is there, and that is what could be causing the block in the movement.
Exactly. So that is what my thought process is now, because the child is yet to come for the next follow-up now, and considering the persistent swelling, now that is my next thought that I know as you see the video, although the elbow is swollen, but the child is able to actively use the elbow without any pain. In fact, I also have a video of him crawling with some full weight on his elbow. So that elbow is painless. So I would definitely keep a rheumatological differential diagnosis.
PGNST is
I
one of
think
the
if you can
differential
see this-
diagnosis, but then age is not this is not a commonest to be present. Yeah.
Yes,
Amit, if you can see the last X-ray, there is some scalloping of the olecranon.
yeah.
So that is probably something which we need to investigate later on.
Yes.
Even
Yeah,
on
right.
medial and lateral view.
So when he comes back, I'm going to get a fresh X-rays, because I'm not sure how and where that notching is. So maybe just rotational or really notching there. But I would keep a high degree of suspicion there.
Actually, scalloping, I've seen, I had two who had chronic elbow synovitis and it turned out to be tubercular. But when there is chronic long standing, it does cause all this other changes in the surrounding bones of the joint. So, I mean, we need to just keep it in mind.
Yeah. So I'm keeping fingers crossed. I would, again investigate him, maybe an MRI, because if you see the scalloping, it is also seen in the lateral views. There's a sclerosis there. I'm not sure what we are dealing with right now, but yes, further evaluation is required.
Viraj sir, could it be primary synovial lesion, like something like synovial chondromatosis that we see in a bit older children? I have seen a couple of cases, not in such a young kid.
Yeah, and again, elbow is not a common
site.
Knee is a commonest site to have this kind of synovial pathology. I would still suggest Amit to just go back and just ask them in detail whether really the child had any kind of sepsis or septic arthritis of the elbow in the past, because that might have caused a damage to the proximal ulna, what we are seeing in X-ray right now, and that fragment was lying over there or like something.
Yes, sir.
Yeah.
All right. So we are done with our cases. Gadegone sir, any last points, sir?
Wonderful cases, and they are all we can say they are educative cases, very different kind of cases, varieties of cases, and I think I have learned a lot from this webinar. That is the plus point of this organization by you.
May I ask one question, please?
Yes, sir.
Yes, sir.
Mandar.
Yes, sir.
Last, I wanted to ask, what is the conscience of the house regarding keeping the K wire outside or inside? Always there is a debate in our department also.
In lateral condyles?
Any fixation with K wire, if you keep it outside the skin or buried. I usually keep it buried because I have got a fear of infection.
So if you ask me, sir, my thought process is that if I have to keep the wires out, wires in the body for more than 4 weeks, those wires go in and are buried. For supracondylars, it is never that I have to keep the wires for more than 4 weeks. So my typical time for supracondylar wire removal is about 3 to 3.5 weeks. So that is the time. So in all supracondylars, the wires are always out. In case of lateral condyle, I'm not so sure about the union. So union can be at 6 weeks or 8 weeks. So at that time, the wires, I always keep them buried. Again, there is a lot of debate regarding it, but this is my thought process. So any fracture which is going to take an unreliable amount of time, better to keep the wires buried. In any fracture where, like a supracondylar, where it is reliably sure that it's going to heal up in about 3.5 to 4 weeks, better to keep it out.
So cutoff time is 4 weeks.
I would agree with Mandar, because I would especially do it in non-union lateral condyle, because the last thing that you can give to the child is infection. So in non-union, when you are fixing a non-union lateral condyle, definitely bury the pins.
Absolutely agree also. Basically, it's whenever you feel your KY duration has to be longer, it's better that it's buried inside. When you know you're going to remove it earlier, as Dr. Mandar said, keep it outside and remove it at 3 to 4 weeks. And in radial neck, sometimes even earlier if required.
And one has to be very cautious while burying the medial wire, if at all you are using the cross pins particularly.
Mandar, you are muted, I think.
So we have had a very good and fruitful discussion about all our sessions. I would like to thank Gadegone sir and Dr. Manoj Pahukar for organizing this. And I hope that this was of use to the delegates who attended this. And I would like to thank Dr. Viraj sir and Dr. Sandeep Patwardhan sir for giving their valuable stalwarts opinions about all the cases. A special thanks also to Amit, who presented his lectures in the car while he was coming back from Amravati on his mobile. So that shows true dedication from Amit.
That was an adventure.
Hello. Thank you very much.
I must thank all the speakers. It was very comprehensive, covering all the aspects of, I think, complex elbow trauma. And the other things were kept very well in the time. All these 5 talks and the 7 cases, we could finish well within time, and that too with good take-home messages. I again thank all the speakers, all the faculties, all the panelists, the MOA team, as well as Ortho TV team, Dr. Ashok Sham and Dr. Neeraj Bijlani for their technical support. And thank you very much, everyone.
Thank you, Manoj. Thank you, Gadegone sir. Thank you, Mandar.
Thank you. How are you?
You can stop live screen sharing if you.
Okay.